Hello, can you hear me?
Yes, sir. Yes, sir, I can hear you. We'll just have a short introduction, then we will start, sir.
Okay.
Okay, so Mr. Paul Trikha, sir, is qualified from St. George's Hospital, London, and completed his postgraduate orthopedic training in London and Southeast England. He has completed specialist fellowship training in knee surgery at internationally renowned North Sydney Orthopaedic Sports Medicine Centre, Australia, and currently he is appointed as a consultant knee surgeon at Ashford and St. Peter's NHS Trust, and as a consultant specialist knee at Surgeon Surrey Orthopaedic Clinic. And he's quite famous in Instagram, so you guys can follow him also. So, Paul, sir, we welcome you to our Mind Academy.
Thank you. I'll just share my screen so we can see.
Yes, sir. I'm making you co-host, sir. Okay, sir, now you can share your screen.
Okay. Can you see it?
Yes, sir.
You can see my PowerPoint, yeah?
Yes, sir, we can see.
Okay,
It's clear.
Hi, thanks for the invitation. Hello to everyone in India. This is one of my talks. This is going to be on osteoarthritis of knee and using an evidence-based treatment protocol. So the key for any knee surgeon, and that's, I know you're all physiotherapists mainly, but I'm a knee surgeon and I have a strong interest in physiotherapy and treating my patients. But the idea is to try and stop patients having surgery early in their osteoarthritis so that when they're 50 or 60, they're not having this salvage procedures. And the earlier they have an intervention from us as surgeons, the more likely they are to get to these salvage procedures at a younger age. So in this first green box, we need to do everything: physiotherapy, pharmacology, repair, reconstruction, but nothing here is joint sacrificing. And these are for any joint really in the body, but definitely for the knee. These are the important pillars of reconstruction. And getting the knee well aligned and rehabilitated and strong are joint number one in importance. Alignment is the key to all knee surgery. In the Indian culture, there's a lot of varus knees, like myself and my father had varus knees and medial compartment osteoarthritis. Stability is the second important, then the meniscus, and then the articular cartilage. And then to go with these, so rehabilitation equals physiotherapy. To realign the knee, you're looking at either osteotomy. I'm not sure whether you have unloader braces in India. I hope you do. The Ossur Unloader brace is very good, and I'll talk about that later. Stabilizing the knee by ligament reconstruction, repairing the meniscus or replacing the meniscus if necessary, and then treating the articular cartilage. So that's my philosophy when I see a patient in clinic. But number one, again, is physiotherapy. And then biology is the new kid on the block, and lots of talk are on injections and biology and regeneration and stem cells and hyaluronic acid and PRP. And if we want to talk about these, please ask me questions at the end on these. But for me as a knee surgeon, meniscus is very topical all around the world now. In the old days, people used to do meniscectomies pretty routinely. And we know that if you do a meniscectomy, your risk of arthritis goes up significantly. And we know that for degenerative meniscus tears, where there is no injury but just a progressive onset of pain that comes and goes, and this MRI shows just the development of a degenerative meniscus tear, just a bit of intrasubstance degeneration, which over a couple of years converts into a tear. And the key here is not just to perform surgery straight away. You know, these will do a lot of the time without surgery. So doing arthroscopy for meniscus is associated with a poor result in obese patients, lateral meniscus, people with bone marrow edema, and people who are going to have a big meniscectomy. And therefore, we should avoid arthroscopy in these guys. And ESCA, which is the European Society of Knee Surgery, and also the British Association of Knee Surgery have given clear indications as to when people should have an arthroscopy, because still worldwide there's too much knee arthroscopy happening. And if we summarize everything on to do with knee arthroscopy for meniscus, is that if you injure your knee and you have a traumatic meniscal lesion and you're going to have meniscal repair, then surgery is indicated. If you do not have trauma and you do not have a significant meniscal lesion caused by trauma, then you always try physiotherapy and rehabilitation first. So simply, traumatic meniscal tears should be repaired, and these are often associated with major ligament injuries. And we know that the meniscus has a blood supply, and if tears are in these areas with the blood supply, the red, white, or the red zone, then they are amenable to repair. This is a bucket handle tear, and this should be routinely repaired. And I think of meniscus when I tell patients of a pair of shoes. On the left, you have a pair of boots with a big heel, and the heel has come off because you tripped on the pavement or something, and you take this to a cobbler, someone to repair the shoe, and you repair the shoe. The knee condition is good. This is another shoe. It's degenerate. The trainer has got holes in it. It's still a torn shoe. The shoe is still ripped. And this is a degenerate meniscal tear. And you can see the articular cartilage is getting a bit thin. This one you have time for. This one should be repaired. And the repair of this is important in osteoarthritis prevention. So what is osteoarthritis? It's a degenerative joint disease causing the breakdown of articular cartilage. Half of all arthritis consultations are for the knee, and it's getting worse because of obesity. Research shows that regular physical activity and targeted exercise are effective in reducing pain and increasing function. This is a major hurdle to go through with patients, maybe particularly in the Asian subcontinent, because they think that people should strap these up or prevent or reduce exercise, and it's quite the opposite. And this is the destructive degenerative cycle of osteoarthritis: deformity, the alignment, mechanical dysfunction, increased loading, so for various knees on the medial compartment, articular cartilage degeneration, causing pain and swelling, quads inhibition, and then you change the way you walk. So patients can present with arthritis, with pain or swelling and muscle inhibition. If they're obese, they can overload their knees. Fixed flexion, this is a major part of this topic. Getting full extension in knees, either preoperative, postoperative, injured in the athlete or the arthritic patient, is the most important thing. Deformity, muscle weakness, joint stability we discussed, returning dynamic function, and getting cardiovascular stability and ability. This is our guidelines in the UK in terms of targeting treatment for osteoarthritis. The key here is education, advice, strength, exercise, weight loss if overweight or obese. And patients don't come to physiotherapists or surgeons in particular for this kind of thing. They want a prescription, they want an operation, they want an adjunct, a brace of some kind. So let's talk about lifestyle advice. This is very important. Cycling, one of the most important adjuncts in exercise. We now know that running is not bad for arthritic knees, but shifting weight is important. You have to tell your patients to lose weight. And exercise is not just good for the knees. It will reduce your chance of stroke, reduce your chance of osteoarthritis, reduce your chances of depression and dementia. You know, me for one, if I get to 75 and my knee is a problem, but I don't have depression, dementia, or cardiovascular problems, I'll be happy, because we can fix the knee. And the exercise requires three major components: the reduction in weight, the increased range of movement, reduced stiffness, and then strength. Strength comes last. Just going to check to see if you can all hear me. Okay, good. And then So what kind of knee program? What works? Exercise 3 times a week. Strength and endurance 2 to 3 times a week. Okay, so this isn't just a once a week exercise with a personal trainer or a gym class. So what are you looking for? We're looking at reduced walking distance, stiffness, pain, swelling, fixed flexion deformity, eye reduction and extension. Early intervention by you as physios will help. So what about arthritis and fixed flexion? Not all patients want or need surgery. 20% of people are not happy after a knee replacement. This is important. So most patients with a bit of education are motivated to find ways to relieve their pain without surgery. Rehabilitation surgeons in the UK, and I'm sure universally, are very poor at prescribing rehabilitation. Using a brace, using painkillers, injections, and wait before you go to knee replacement when all else fails. One of the myths about treating arthritis is that increasing strength is the way forward. Stop what you're doing, reduce your exercises, and fixed flexion is fixed. And this is simply not true. You have to get the motion back. You have to get the pain down. Then you get the strength, because you cannot strengthen a stiff knee. So myth 2, adjust your lifestyle, take it easy, don't do anything. No, the pain gets worse. And this is important. When you have a patient with fixed flexion, you must try and reverse it. And this is possible without surgery. You can get symmetrical extension, because when I do knee replacement surgery, I do not see symmetrical extension. And you need full extension for your VMO to function normally. Arthritic knees with good range of movement will do well. Okay, so you know all this in terms of exercise. Do whatever it takes. Do whatever it takes to get your extension. Use towel stretches, heel props, any extension device if you have one, but go slow because these hurt. So regain lost range of movement, get full extension so the VMO is effective. Do your deep soft tissue work at the back on your posterior capsule. Do it on your dominant hamstrings, your gastrocnemius. Mobilize your fat pads. Do patellofemoral mobilization. Do your prone leg hangs and home stretch routines. Recover movement where possible. And if your surgeon or your doctor needs to give you painkillers or injections to help you, then so be it. So those are some of the exercises we were discussing. Get extension, then flexion, then strength. And if you have severe pain and you can't do the above, then maybe a steroid injection. Shelbourne looked at 207 patients in 9 months with 90% moderate or severe arthritis. Most did well without surgery. What about braces and insoles? So we know some mechanical adjuncts, walking sticks, braces can help. We know lateral wedge orthotics can also reduce the various components. But one of the main things I want to talk about is unloader bracing. These unloader braces will offload damaged compartments and preserve the joint space as is shown here. They work by distraction and reducing compartment load. They increase proprioception and reduce the moment force. They do not cause muscle weakness, but the patients have to wear them. So a number of studies have happened on the Ossur Unloader, where patients have gained functional gains. Our paper, which is in press, looked at 509 patients over 5 years. 83% had grade 3 or 4 arthritis. 80% have had no surgery. This has given, in our hospital, a saving of close to £1 million in reduction of number of knee replacements compared to our peers in the country. The blue is our number of the cases, and the red are the average number in equally sized hospitals. So what about knee replacements? It's not all that bad, but we do know that the success following knee replacement is overstated. Only 10% are extremely happy. The majority are happy. They're glad, but not happy. They'd like to be better, but the knee functions better than it was, but it's not normal. And this is a real figure. If you are 50 years old and you're thinking of knee replacement and you still work, having a 15% chance of complications or being much worse is a problem. So you must try non-operative treatments where possible. I use a knee in the UK called the MRK. It was in India briefly before they were priced out of the market. And the revision rates are extremely low. The functional scores are very good. My mom is a high BMI Indian lady. She has 2 knee replacements. She can sit on the floor in the temple, cross-legged, and stand up without help. So functionally, the knee is good. So let me see. This lady is 2 weeks after a knee replacement, walking down the hospital. Look, you can see her stockings following surgery. Her gait isn't perfect, but it's not bad 2 weeks after knee replacement. This is another lady. She's 92, 2 weeks after a knee replacement. People think people are too old for a knee replacement. If they are bad enough, they can have it. So this is a 2 weeks. This guy's 6 weeks following knee replacement.
And back.
And this guy's 2 weeks after second side knee replacement. Okay, so these are obviously very good patients and good results. And I wouldn't be showing my poor results here, but I'm saying that knee replacement isn't totally bad. If you get it right, it can work and can be life-changing for some people. Like this gentleman who's had a knee replacement, can run and function. And the main reason I use this knee replacement is stability. And thanks for inviting me to your educational seminar. If you want to follow me on Instagram and see some of these videos, Surrey knee surgeon. And obviously, if you ever make it to the UK and want to travel to see me in operations, you're more than welcome. Thank you very much.
Thank you very much, sir.
Any questions?
If anyone has any question, they can ask.